Welcome to our live discussion, key learnings for patients from GI ASCO 24. I'm Kim Newcomer, Director of Volunteers at the Colorectal Cancer Alliance, and I'll be your host tonight. Joining me, I have Dr. Pashtun Kasi, Director of Colon Cancer Research at Weill Cornell Medicine, David Fenstermacher, our Senior Director of Research and Medical Affairs at the Colorectal Cancer Alliance, Allison Rosen, Advocate and Director of Project ECHO at ACS, and John Warner, Survivor and Alliance Board Member. Welcome, everyone. I hope you're all well and rested from GI ASCO. Well, thanks again for being here. Now, at GI ASCO this year, we heard a lot of rumblings from patients and oncologists talking about CTDNA, CFDNA. Is the liquid biopsy here to stay? David, do you want to take that on to start?
Yeah, thanks, Kim. There were some interesting studies that were reported out based on ctDNA. One was the blood-based screening tests that are really now becoming available based on this technology. And some of the tests that are out there are achieving significant improvements in detecting colorectal cancer, even in early stages, such as stage 1 or 2. But some of these tests are still lacking in the detection of precancerous adenomas. And so that certainly is a concern. But I think the exciting news here is really the fact that we are getting close to not necessarily colonoscopies, but still in the 90% prediction range of whether you will have colon cancer or not, based on a blood-based test. And of course, that will increase the number of people getting tested. So I think that's extremely exciting. And of course, everyone agrees that these tests will continue to improve over the next couple of years. The other thing I will bring up is basically there were some studies that showed that using ctDNA to look at minimal residual disease following a resectable tumor, meaning you were able to get the tumor taken out by surgery, really did not provide a lot of clinical benefit. But at the same time, all of the researchers that were part of the panel agreed that they would continue to use it. And that, again, this is just the beginning of this technology. And really, when you see it being applied on how you can make decision treatments about whether a patient should go on a treatment or not using a blood-based technology, I think is extremely exciting. So I think it's just the beginning of the use of this technology, ctDNA and cell-free DNA. And I just look forward to even hearing more at ASCO this year and in the years to come.
Yeah, I think the ctDNA, there were probably half a dozen or more studies utilizing it. And to me, it is a critical tool for a patient to have in the mix. And I urge all patients stage 2, 3, or 4 to make sure they're getting it. And I think we're really living through, really redefining how we talk about colorectal cancer. What the Intercept abstract really struck me, which was, right, I'm a stage 4, thankfully, of NED, but stage 4 and KRAS mutant patient. Two bad labels, right? Stage 4 and KRAS in terms of overall survival. But what Intercept showed was stage 4 NED patient who's ctDNA negative has a 74% disease-free survival, but a stage 2, regardless of your KRAS mutant status, who's ctDNA positive, is a 16% disease-free survival. So my odds are 4 to 5 times better than a stage 2 patient who's ctDNA positive. That, to me, is reframing the conversation around how we think about recurrence risk, and it's something that I think each patient should have that testing done and use with their oncologist to understand where they are.
And Dr. Kasi, did you want to add anything? I know you're working on a few things in this area.
And as some of you might have seen, one of the largest first prospective U.S. studies, which was the Bespoke CRC study with over 1,800 patients and across 130 centers in the country enrolling to it, and that too in the middle of pandemic. That kind of shows, to John's point about the interest in the field from a patient and caregiver standpoint. And I like the comment that you made to kind of add to the mix. I think one fallacy that's being made for ctDNA as a field and scientific community is you can't put that test as something that's in the other room, so to speak. It has to be taken into context, the stage of the patient, the exact patient scenario. And when we look at the pathology report, just like to John's comment, the KRAS mutation, other aspects to the pathology report, we look at that as in its totality, not separately. I think ctDNA is already pretty powerful, but if you added that to the clinical armamentarium, I think it would even be a more powerful predictor of what treatment decisions that we would like to make. And we also presented some interesting research about the patient perceptions part, and the question of, are we helping our patients, or is it just increasing anxiety? I think there is a lot more to the dimensions of well-being of what testing that can do. So I think it was a lot of good data presented at the conference.
Excellent. So I'm glad that you brought up KRAS, because I must have heard at least 10 times from different doctors and oncologists that 2024 is the year of KRAS. David, do you want to expand on that a little bit of any new studies or new drugs that might be coming online?
There were several studies about the KRAS drugs, mainly in G12C, which are the drugs that are currently out there. Very exciting news. They work extremely well, especially when combined with an EGFR inhibitor, with around 45% objective response rates, which is really great. Unfortunately, G12C is only about 3% of colorectal cancer patients. And it was great to hear from some of the companies and even some of the posters that were presented at the conference that there are new drugs in the pipeline for G12D and G12D. So hopefully these will be coming out soon and being able to help patients. But we also heard from a couple of companies that they're looking at working on what we would call pan-mutational KRAS drug, meaning doesn't matter the mutation you have, it would work. And so, like I said, several companies are working on a G12, what we would call X, so it doesn't matter what the substitution is, but that these drugs would work. Another breakthrough that came through is that most of the current KRAS drugs that are out there, again, targeted for G12C, only bind to what is called the inactive form of KRAS. But a company has now developed a drug that will bind both to the inactive form as well as the active form. And the difference is the active form is what creates the signals in the cell to reproduce itself. So basically creating the cancer cell environment that allows it to reproduce rapidly. And so very interesting to see in a phase 1, 2, and B that, they are able to demonstrate that this particular drug is able to be effective. And the interesting thing here is it's not yet available, but it really may be able to overcome some of the non-response and resistance that we see in the current KRAS drugs. So lots of exciting things happening. I think that this is just the beginning and why they call it the year of the KRAS drug, because clinicians and oncologists are really going to learn how to use these drugs going forward, and what combinations are going to be most effective for CRC patients.
I just want to put a small plug in for the KRAS vaccines as well. That we actually had the privilege to be a part of this, and one of my patients who's KRAS G12D with metastases at the time, like John said, rendered NED, but then was still ctDNA positive, meaning not cured. Was able to complete the 10 vaccine course. It's almost like a year and a half, 2 years out, and on nothing, and that's something that a few years ago I don't think I would have imagined that would even be possible. But these are tangible realities happening right now, not necessarily in the future. The full paper just came out in Nature Medicine and was looking at both colorectal cancer and pancreas cancer, and technically it's an off-the-shelf KRAS vaccine, so it doesn't really matter what specific type of tumor you have. But the fact that it was also working in colorectal cancer as well, hopefully as they pave way with the pancreas cancer, it will also help our patients with colorectal cancer as well.
That's
Amazing.
a great highlight, and I'm chatting with patients, whether KRAS or whatever your mutation is, back to the minimal residual disease tracking that Dr. Kazi spoke about. I do stress them, look, if you're NED and you get a positive ctDNA test, there are options. There's probably about a dozen MRD trials going on now that you should raise and discuss with your oncologist and see if it's right for you or not. But we're well beyond the days of, oh, if you're ctDNA positive, there's nothing I can do until something shows up on the scan. It's just not true.
True. Even earlier, a few hours ago, there's, with the wave of the vaccine and pandemic, there are personalized vaccines, there are off-the-shelf colon cancer vaccines, and there are mutation-specific vaccines. A lot of them are focusing on the MRD positive, CTDNA positive blood tests, but nothing on the scans patient population to kind of intervene earlier before you develop metastases that are visible on the scans.
All right. And before we move on, I want to talk about one thing that's really important as we're talking about KRAS, and I know we're talking about treatments and immunotherapies, is biomarker testing. I know this is something John had seen an abstract at ASCO he wanted to chat about as well.
Yeah, there was an abstract. It was a 7-year study. The data was through the end of 22, so it's not this last year, but very recent, right? And it was around patients, stage 4 patients in third-line treatments that were being treated in community oncology settings. And I'll read you the stats. Very shocking. 25% had still not been tested for KRAS. 77% had not been tested for HER2 mutation. And 35% had not been tested for MSS, MSI. So again, biomarker testing. Do make sure that you've talked about it with your doctor and had your genetic mutations, your MSS status, your HER2 status tested for sure.
Yeah, that's so important, especially as we're going into our next segment, which is immunotherapies. We know they're still making headlines. David, what are we hearing about immunotherapies?
Oh, wow. There's so much going on, not just new, but also things that have been in the pipeline for quite some time. If you look at nivolumab and ipilimumab, I'm sorry, I hate these names, but looking at basically the Bristol Myers Squibb drugs, if you look at first-line therapy, they just did a 4-month follow-up. And, for those patients that had MSS high, after 5 years, there was more than a 70% survival rate for those that responded, which is really fantastic. And the other thing is 97% were no longer being treated. So they were treated initially with the double immune therapy. It basically is PD-L1, PD-1, or CTL and CTLA-4 combined. And basically were not even being treated anymore and remained cancer-free, which is extremely exciting. Also exciting news around immunotherapy in the neoadjuvant setting. I'm not going to steal Dr. Kashi's thunder, but there's some really exciting news here. And the fact that, normally we would think about the fact that you could use chemotherapy in the neoadjuvant setting, meaning you had a resectable tumor, that you could get chemotherapy before the surgery, hopefully reducing the tumor itself before surgery, and then also reducing the chance that there will be tumor cells that will get into the blood or the lymph system that will create a metastasis. So, this is exciting because the side effects with immunotherapy tend to be much less than you see with chemotherapy, and some of the results are really striking as far as how immunotherapy is able to improve the outcomes for patients when they do have a resection going forward. And then the other thing I'll just say is there were many posters about new immunotherapy methodologies they're looking at, different targets that they're looking at. They're very cancer specific. These are early stages, basic research at this point, but certainly there is hope that some of these early findings will be able to be translated into new therapies going forward. So again, I think really exciting news at ASCO-GI, and looking forward to hearing some updates at ASCO later in May and June.
Excellent. And we're going to get to Dr. Cassie's poster or an abstract in just a minute. We'll hear all about what he's been working on. But next, we're going to go to our patient segment and talk about the supportive care session. Allison, I know you attended those sessions, and we've got a lot of really great information and to give our allies. So what about starting with fertility?
Sure.
So session.
I think fertility preservation isn't talked about nearly enough. And so first of all, it was great to see a supportive care session at GI ASCO where they talked about sexual health, fertility, LARS, and different ways to decrease treatment methods and medicines in order to decrease the amount of long-term effects and survivorship, because we all know and we all heard from Kimmy Ng in her session that early age onset especially is on the rise. Under the age of 50, colorectal is number 1 in men and number 2 in women. So I urge patients when I talk to them, other people that are going through treatment that find out I'm an advocate, to ask about fertility preservation on the first day. They usually can rush this sort of stuff. So no matter what age you are, even if you have children, if you think you might want to have children in the future, there are options for you for females and males. Back when I was going through treatment 12 years ago, there wasn't. All of these were not available, but now all these are. There's many different things that can happen. So I'm not going to read them all, but fertility preservation is something you need to ask your doctor about on the first visit so that you can get this done before you actually start treatment, especially if you're going to have pelvic radiation. Some of the chemotherapies might be toxic. So it's really, really important to talk about fertility and have that shared decision-making conversation with your provider. I think the next thing we're going to talk about is sexual health. And that is so often not talked about at meetings like this, but it's such a concern. I had radiation, it put me into menopause. And if you look at these numbers, it's shocking. 75% of patients with CRC experience sexual concerns. A lot of people don't have sex afterwards because they have dysfunction. And that's men and women that are affected by the treatment related to colorectal cancer. And these numbers show that the importance of interventions related to this. They talked about pelvic floor therapy as one. They talked about all different things and conversations. Again, shared decision making. Conversations you can have with your provider about this, because it's about quality of life. And so having this conversation early is so important. Female, but 100% men as well. Don't be shy and have that conversation, because again, especially with early age onset, but no matter what age you are, partner or no partner, you want to be able to have a long and healthy sex life after, even during treatment, if you want that. And then I think we have one more slide, if I remember correctly.
One quick comment, Allison, on the slide. Anecdotally, I had a patient, young lady last week who, again, going back to David's question about the G12C inhibitor, where the toxicity of some of these novel therapies is so less compared to just accepting what chemo and radiation and surgery does, that the young lady was concerned and also, as you mentioned, not comfortable about bringing up the fact that the sexual function actually was returning because of probably lack of toxicity from chemo, which was kind of like a given norm, so to speak. So I think it's cannot underscore the importance of this, not necessarily just young patients, but both males and females. And that's something that often is ignored and just accepted as the norm, which some of these novel therapeutics are also changing.
Yeah, and I also think another theme that popped up that has been around since I think last year, but also was a part of this session, was less is more. So they talked about less oxyplatin versus more. If the benefit isn't, if there's no benefit giving more than less, then you should give less, because the side effects and the quality of life is better with less medicine. I mean, that's just something sort of common sense, but that was a slide that popped up, and I want to make sure that everyone knows about that. I think they talked about it, I think last year, either at ASCO or GI ASCO, about K-pox, talking about it with oxyplatin, talking about with, various surgeries, but there's even potentially the option, again, having that conversation with your doctor about reducing radiation based, or not having radiation based on some of these new therapies that are out there. And, again, 12 years ago, a lot of this stuff wasn't available. So I really, really urge people that are newly diagnosed or know someone that's going through treatment to have this conversation with their doctor, because, we have a lot of life left to live, and we want to live it to the best of our quality, and having that conversation about what's best for you. Some of these, again, immunotherapy, you're 100% correct. There's a lot less long-term side effects, a lot less side effects than some of these very, very harsh chemotherapy drugs that are often used with colon and rectal cancer.
And I think that patient versus clinician values in the rectal cancer, I think we have one more slide to talk about, which I think is really important.
Yeah. It just shows shared decision making. What the clinician thinks are the most important things to a patient are not the most important things to a patient. So, I mean, I think it also talks about, I think it stresses having that conversation, having a patient potentially talk to another patient as well that's maybe gone through treatment. Because if you look at this colostomy for the patient's number one, and it's down at the bottom with clinician, patients highly value quality of life and avoiding a stoma. I think I thought that at the very beginning. If I had talked to a patient at the time, that might have changed my opinion. I live a very good quality of life with my permanent ostomy, but I was very much, I had this negative stigma about it. I didn't want it, would do anything to not have it. And I had multiple surgeries as a result of not getting it permanent the first time. So I think looking at all these different challenges, what's more important, what does the clinician think versus what the patient thinks? So shared decision making and having these conversations about all the things we mentioned: sexual dysfunction, living longer. I mean, you want to live longer, obviously, but worries about cancer recurrence, that's lower in a patient versus, all the dysfunction. And again, when I saw this, I was very, very surprised that an ostomy was number one, because, I do my best, and a lot of ostomates do their best to break that negative stigma that exists there. But I had another thing that was talked about a lot was Lars, lower anterior resection syndrome. And I had that, and my quality of life was not great. Finally, I decided with my doctor to have my ostomy made permanent, and my quality of life improved. I went on multiple trips, 2 international trips, hiked a mountain, gone skydiving, all because I have an ostomy. So I always say that an ostomy saved my life, but that conversation needs to be one that you have with your doctor to decide what's best for you. What type of life do you live? Are you very active? Are you more sedentary? So this is very interesting. This again, I think I've said shared decision making 100 times already, but really knowing what's the most important thing to you and talking to your doctor about it, so they can tailor the treatment to what works best for you and your lifestyle.
Yeah, it's all about having those open conversations with your doctor. Yes. So thank you, Allison. Thank you. All important topics, right? So now, really exciting work Dr. Kasi is doing with his next, is it phase 1 clinical trial? You're talking about?
Yeah, essentially it's technically phase 2 or phase ability, because technically the drugs, we already know the safety part, but in the trial, because we're giving it in the neoadjuvant setting, meaning before surgery happens, just that testing it in that setting from a feasibility standpoint had not been proven before. So this was the first time these new drugs, as David had mentioned, like the CTLA-4 and PD-1 inhibitors, kind of like the next generation of them. In this case, the so-called botensilimab or the BOT, and then the balstilimab, which is the other PD-1 drug, kind of like the Ipi-Nivo, as David was mentioning. This is from the genus, and this is the poster that we presented in there was a lot of exciting. If we can go to the waterfall plot slide, it kind of summarizes in a nutshell what we saw. And patients in dark green are the one who are the so-called with MSS tumors or cold tumors, so they don't necessarily respond to immunotherapy, and the expectation to respond here. And there's some studies done a few years ago from Dr. Shalabi and the team looking at the other drugs like Ipi-Nivo. So it's not a whole lot in terms of responses. So the fact that we were seeing almost every single patient's cancer respond to quite a fair degree of extent, and even melting away to the point there was no cancer found in the scan. So it was very exciting, on a weekly basis at our tumor board meeting where we review everybody's case, and the subjectivity with which our pathologists were describing the response in terms of it being exuberant or something like they had never seen before, or the fact that, what did this patient get? What did you give him, or her? So it was really rewarding to kind of see. And not surprisingly, in MSI high cancers, pretty much there was no cancer every single time. If we go back to the poster, we saw some intriguing insights about the mechanism of action, and also how the cancer was being killed or eaten up inside out by your body. So hopefully it was eradicating the micrometastatic disease, as was pointed out regarding the value of CTDNA and MRD positivity to see who's cured, who's not cured. All the patients that have been tested so far at more than 30 time points have been negative on the commercially available testing. We're doing some more in-house testing as well. But the fact that everybody was able to have no ctDNA post-op, the fact that none of their surgeries were delayed, that was most important, because I think our main goal was that nobody's surgery should be delayed by more than 12 weeks. So we had one person with diarrhea that was managed the same day with some of these new drugs that just can uncouple the toxicity from the efficacy. So the diarrhea went away the same day. The patient wasn't even admitted and still got surgery 4 days later on a Thursday. So, those are things that we are very excited with this bot or botensilimab drug, which some people are saying is the next generation of CTLA-4. But as we understand the mechanisms, it's probably not as simple as just this next AP, but it's more so like a multi-immune activator, so to speak. And, from some of the work that we're doing with, some of these immune biomarkers, it's showing that there's multiple mechanisms downstream of the circuitry. So we're really excited, and the study is now expanded to study the question of letting immunotherapy brew for a little longer to see if it will kill more cancer, and maybe even do or spare surgery in the MSI high for sure.
It's really exciting to see that response chart, and then more broadly to see folks like you trying immunotherapy earlier and earlier for MSS patients. It's really opening up some amazing results. Curious, and I looked at that, it did look like there was a bit of correlation. I know it's small numbers, right? A bit of correlation with the ones on the left, that the biggest and deepest response seemed to have higher tumor mutational burden. They were still all under 10, but they seemed higher. Do you think there is a correlation there with the depth of response, or is that a guess at this point?
Actually, we didn't see much of that in some of the platforms. It's coming a little inflated, but it was more so the days till surgery, which was the strong. Again, keeping in mind the small numbers, but the folks who are on the left side of the curves are the ones who enrolled later on, so they were comfortable in waiting a few more weeks longer. And the surgeons also, every single patient came with a surgery date in mind. So we were only postponing surgery by a week or two. So a lot of the patients had surgery as early as 3 weeks into therapy. And as you can imagine, any clinical trial, any treatment, they usually wait 2 to 3 months to assess anything. So the fact that we were assessing things as early as 3 weeks into therapy, I think that just needed more time. Of course, the expansion of the trial is going to test the hypothesis of surgery at 8 weeks. But anecdotally, the ones who are 100% are the ones who had surgery at the 6th week, 7th week. And the ones who are in the lower threshold range are the ones who had surgery less than a month in time.
Okay.
And also across different age groups, we talked about young onset colorectal cancer. We had a lady as old as 26, and then of course the second peak in our elderly, somebody as old as 78 enrolled in the trial. So we're seeing benefit across races, across age groups, and across mutations as well. Half the patients had KRAS mutations, and in a good way, it's not a biomarker other than the fact that we did a neoadjuvant. Something about the cancer still being in your body, the mothership, and before surgery, our surgeons tell us that they perturb the environment, that doing something before we do our part, it's important and might be kind of like the paradigm shift, as they call it, happening across all different tumors, not just colon cancer in our case.
Really exciting work. We look forward to seeing more. So, well, that's all we have time for today. I really appreciate Dr. Kasi, John, Allison, and David being on here tonight. I appreciate all you do, and thank you for being here for us and for our patients and allies. And we look forward to seeing you at our next live. Our next live will be on ASCO, which is just a few months away. So I look forward to seeing you all then, and have a good night, everyone.
Thank you.
Thank you.
Thank you.